Thank you for your kind introduction. I am going to present about the lipid-rich necrotic core of basilar artery plaque. The MR imaging of a lipid-rich necrotic core is very important when evaluating the response of lipid-lowering therapy. As we all know, lipid-rich necrotic core plays a key role in progression of arteriosclerotic plaques, especially in carotid arteriosclerotic plaques. In our study, we use contrast-enhanced T1 weighted imaging to evaluate the LRNC. Basilar artery arteriosclerotic plaques can protrude into the perforating arteries and can cause narrowing and obstruction of the lumen, leading to a possible infarction. A previous study reported an association between intraplaque hemorrhage and territorial acute infarction in patients with basilar artery plaques. The purpose of this study was to evaluate and identify features of the lipid-rich necrotic core in patients with basilar artery plaques using CET1W imaging. To conduct our ex vivo histological study, we retrieved samples from 11 autopsied specimens. The histologic findings of the plaque from each sample were analyzed, and the plaque complications were assessed when applicable, especially for any ruptured fibrous caps or intraplaque hemorrhages. For the patient study, we enrolled patients who underwent conventional brain MRI to detect neurological symptoms. Any coexistent vertebral artery stenosis or luminal irregularity and non-arteriosclerotic vasculopathy were excluded from the analysis. Among the 130 enrolled patients, 35 patients were excluded according to the exclusion criteria, and the 95 remaining patients were included for the study. We used a 3 Tesla MRI with 16-channel head coil. High-resolution MRI protocol was as follows, including the contrast-enhanced T1 weighted imaging. 2 experienced neuroradiologists assessed the MR image quality to find the basilar artery. The CET1 weighted image was the reference sequence for identifying a lipid-rich necrotic core. We analyzed the maximal wall thickness and stenosis degree for any luminal stenosis and plaque found in the basilar artery. To carry out the statistical analysis, continuous and categorical variables were compared using the Mann-Whitney test and Fisher's exact test. We assessed 20 arteriosclerotic lesions from the histological study. Of these, 18 lesions had an eccentric plaque and 2 lesions had a circumferential plaque. Most importantly, all 20 lesions had a lipid-rich necrotic core. Figure 1 shows the results of the ex vivo study. The first image, A, is a basilar artery with multifocal yellowish arteriosclerotic plaque. The second image, B, shows the 3 layers of the plaque, the adventitia, fibrous cap, and the intervening lipid-rich necrotic core. The final image, C, is the histological finding of the lower arteriosclerotic plaque with interplaque hemorrhage. The demographic data and plaque characteristics of the 95 patients are described in the following tables. Table 2 is the diffusion-weighted image findings of the plaque and measurement results of the plaque burden. Of the 95 patients included in the study, 10 patients were identified with layered plaque with an LRNC on CET1W imaging. Of these 10 patients, 9 showed significantly higher diffusion restriction, while those without LRNC showed much lower diffusion restriction, 43.5%. Also, LRNC positive group showed more maximal wall thickness and higher stenosis degree than that of the non-LRNC group. This figure 2 is the brain image of a 78-year-old male. After the volume rendering reconstruction using time-of-flight MR angiography, image A shows diffuse narrowing of the basilar artery with a stenosis degree of 67%. In the DWI image B, multiple high signal intensities were observed in both occipital lobes. In the CET1W image C, we can see the luminal narrowing of the basilar artery due to layered plaque. The black arrow indicates the enhanced fibrous cap, and the open arrow indicates the adventitia. And between the arrows is the intervening non-enhanced LRNC. The widely accepted hypothesis is that the lipid-lowering therapy uses statin to reduce plaque instability and carotid vascular events. In previous studies, carotid plaques with a larger LRNC were associated with higher risk of fibrous cap disruption and ipsilateral stroke events. Therefore, LRNC detection of intracranial arteriosclerotic plaque using vessel wall MR imaging is very important. As we all know, a layered plaque is considered as a unique finding of the lipid-rich necrotic core on CET1W imaging. In our study, all visualized layer plaques in the basilar artery were associated with thicker wall and higher degree of stenosis. Therefore, these findings suggest that VMMR imaging in patients with a large BA plaque volume can show a layered plaque. In conclusion, we found a LRNC in intracranial arteriosclerosis on histologic findings, and all BA arteriosclerotic lesions in our ex vivo study had a LRNC. A layered plaque with an LRNC on CET1W imaging was related to higher grade stenosis and massive plaque burden of a BA arteriosclerotic plaque. Therefore, most BA arteriosclerotic plaques found on vessel wall MR imaging could be an indication for lipid-lowering therapy. Thank you all for listening.